All right, friends, we're going to jump in. It's 8:05. Britt will mute everybody. I'll unmute myself, and we'll get rolling. All right, everybody, it's so good to be with you as part of our practice for these. I'm going to read us our baptismal question, use this as a time of prayer, and then we'll go into prayer, and I'll close us, and we'll get our night going. So let us be in a spirit of prayer. Do you confess Jesus Christ as your Savior, put your whole trust in His grace, and promise to serve Him as your Lord, in union with the Church, which Christ has opened to people of all ages, nations, and races? God of all people, we come before you with open hearts and expectant hearts this day, spirits eager to learn and be transformed, God, to bring about greater wisdom, so that in our wisdom we come to this world with greater compassion and mercy. God, you are a God of mercy and compassion. So in this space, in this time, this evening, as we have conversations around the medical inequities of our world, may there be healing that takes place, oh God. We ask this in your name, God, as you have created each and every one of us in your image. Amen. Tonight, as we get ready to dive into this conversation, I'm going to do a Cliff Notes reading of the parable of the Good Samaritan. As you know, Jesus was approached by a lawyer to teach him and to test him. And teacher, he said, "What must I do to inherit eternal life?" He said, "What is written in the law? What do you read there?" He answered, "You shall love the Lord your God with all your heart, with all your soul, and with all your strength, and with all your mind, and your neighbor as yourself. You have given the right answer. Do this." And we know where this goes. We see it playing out, and people keep on passing by the man who was beaten and left for naught on the side of the road. Then finally, the Good Samaritan shows up, and he has pity on him, and he takes and has mercy and compassion on this gentleman who is beat up. This gentleman who is not of a group of people that the Samaritan was supposed to interact with. It was somebody that was from a different culture, a different background, a different standing, a different social place in life. And he came and he took them to the inn. And this is where I really want to dig and focus for a couple minutes. I've always been struck by this portion of the scripture here. He gets them to the innkeeper, and he takes out two denarii. And he says, after he pays them that, which would have been a really good pay, he says, "Do whatever it takes. Heal this man. Take care of this man. Give this man all that he needs, and I'll pay you back at the end of it." And I can't help but think about the beauty of that and the intentionality of that care, and of that giving that dignity and worth to the person who was beat. That it wasn't just like pick them up, heal them, drop them off type of thing, or get them to a day. It was this continual idea of caring, this continual idea of investing into somebody's life, and investing to make sure that that person would be able to get up, to be fully healed, recovered, have marks of well-being in their lives. And there's plenty of scriptures about healings that have happened, but I think that one really speaks well to the conversation to tonight, is that there's so many things in our world, as we well know, that are broken and that are awry. Medical is definitely one of those. It's a systemic thing that we're wrestling with and dealing with. The medical world, the segregation that has caused that. And I think about, like, gosh, what would it look like if we've created systems, or deconstructed systems and reconstructed systems, that would continue just to care, that would continue just to pour in and pour in and pour in into the inequitable places of our communities, so that everybody would have access to equitable health care. And I think that's the biggest thing, having that access. The Good Samaritan gave access to this man through his awareness of him. And so I just use that to frame us up for this evening. We have two amazing guests with us tonight. We have Dr. Jessica Shore-Sachs. Dr. Jessica, she has been with us on a handful of times within our church building. She's been just a wealth of knowledge and wisdom and guidance and conversation. And so we're so thrilled to have her. And she has invited her friend, Chiamaka Okonkwo. And so we're excited for her to guide us in conversation. And now I'm going to turn it over to Jessica to give some more thorough background and bio on both of you. Thank you so much for guiding us.
Well, actually, I'm going to give a little background about what we're going to do here tonight. And I like that story, and I like the idea of investing in people. One of the things that you're going to hear us talk about tonight is people usually think of healthcare as healthcare and what doctors do and so on. And one of the things that you'll hear us talk about is some other things like poverty and access to housing and things like that. And the reason that we talk about that now is because it has finally become recognized that those things which are now referred to as the social determinants of health are actually as important, at least as important, as what we typically think of as healthcare. So when you hear us talk about those things, really realize that those are really important to health. I'll say a little bit about my background later, but I want to make sure that you have a good appreciation of Chiamaka. Chiamaka and I are both part of the leadership of Healthcare Justice North Carolina, which you'll hear us talk about a little bit more later. Chiamaka started the student chapter at UNC Charlotte, and she comes to our board meetings. And I just want to tell you, as by way of introducing her, that all you need to know is she's dynamite. And she and her colleagues, they've not only done great things at UNC Charlotte, but they're always inspiring our board and energizing us. And so I will now turn it over to Chiamaka to start this discussion.
That was such a kind introduction. Thank you so much, Jessica. That was lovely. Thank you all for having us here tonight. It's been great, and I love that this conversation is happening. I'm studying biology and public health at UNC Charlotte, so this is something that we're always talking about, healthcare disparities, talking about how other social factors play into that. And I think it's really important to talk about the systems that do kind of play into that. So I think this is a great conversation to have, and I love when someone had talked about reconstructing and deconstructing systems, because that's what we're trying to talk about today. And so I'm going to try and share my screen. I'm not sure if it's going to let me. I just have a couple pictures to try and help follow along. Let me see.
If that were, if not, I can.
I think I might have to get the permission to do so.
Okay, I'm going to, just to quickly, I'm going to make you the host.
Okay. I'll hand
for
it
your
back
time, and you can shift it back to me.
Sure.
Because I don't know how to do it otherwise.
You're fine.
And while that's happening, I forgot to remind you all, just please put questions or things that arise in your heart and mind into the chat, and we'll address those midway through. Thank you.
Perfect. So I think this is coming up. Let me see. Right there. I'm going to share just a couple pictures. Let's see if they'll come up. Present. Okay, so one of the things that we're having conversations about while this loads is healthcare disparities. Healthcare disparity is essentially just talking about differences between groups in health. And often that's not necessarily based on personal choice or individual factors that are contributing to differences between groups, but there are actual things that are in structural effects that are impacting these groups disproportionately compared to other ones. And so here's just a chart that I got from the North Carolina Department of Health and Human Services that kind of outlines some of those that we might talk about today. And so, for example, you can see some of these subcategories with Black, Hispanic, Latinx, American Indian, or other, and then some of the different health outcomes that come out of that. And so each of these colors is pretty simple. Each of these colors represents either red, that this group is doing worse compared to white populations, or green, that they are doing better, or white, maybe they're the same. And so you can see there are differences between groups. A lot of this chart is red, which does show us that there are some issues in terms of health outcomes between these groups and compared to white individuals. And so that kind of highlights some things that we might need to focus on. But there's also some that are green. So it's also important to notice that there are some maybe community factors or protective factors within some of these groups that actually make some of these groups less susceptible to certain diseases, such as cancer, heart disease, and the Hispanic community. So in general, it's important to realize that there are differences, but then also delving deeper into why those differences exist is also really important. And so that's what Jessica and I are going to go ahead and try and do today, along with the guidance from some of your leadership. And we're just going to go into some of those topics of discussion, talking about the structural effects that are actually leading to those, the individual effects, maybe one-on-one interpersonal issues that might be causing some of these disparities, and then also talking about the bigger picture. What can we take away from this? What can we do past this conversation to enact change in our communities? And so I'm going to stop screen sharing, so this is a little bit more personal, but I'll go back to screen sharing just a couple more pictures after this. But we're going to talk a little bit first about barriers to accessing care. Can you all still see me? Yes. And so we're going to talk a little bit about barriers to accessing care, especially in some of these marginalized racial groups. There was a podcast that was shared. If you got the chance to listen to it, that's great. If not, then there are some really big takeaways from it. It's a podcast in the New York Times that talks about some of the individualized personal effects that the healthcare system has had on some of its speakers, but also talks about the structural effects that healthcare disparities and healthcare systems have actually had on Black people as well. One of the speakers mentioned that her uncle had lost her employer-based health insurance and then had experienced back pain for months and months and months, was not able to go to the doctor because they did not feel like they could go after their insurance had been discontinued. And eventually, very unfortunately, they were diagnosed with terminal cancer. And they had realized that if they had gotten that treatment months prior, then maybe they would have been able to access that care and not eventually have died from that condition. And so it brings to light some of those issues, such as access and talking about insurance based on your employer, and talking about how some groups are actually barred from those employer-based insurance plans. And so when we're talking about, for example, Black individuals, there's a lot of historical effects that have come into play here that have barred Black individuals from getting that health care access. And one of those is very direct in terms of employer-based health insurance. Due to Jim Crow, historically, Black individuals and other marginalized groups did not have the jobs that maybe today would provide full-time benefits like health insurance. And so that's one of the big factors that has really played into when we talk about, for example, Black Americans being more likely to be uninsured. They're twice as likely actually to be uninsured compared to white individuals even today. And then on top of that, for example, Black individuals are more likely to be found in the South, in states where Medicaid wasn't expanded, which would have expanded coverage to more people who fall in that lower income to middle income area. And so when we're talking about some of those structural factors that have historically been put on Black and other marginalized groups, it's important to realize what are the barriers that are keeping people from accessing this healthcare, and what can we do to kind of change those systems. So that's one of those, talking about our past and those hiring practices. Another thing is income inequality. A lot of these things go into a lot of the different social aspects that are not necessarily related directly to race, but do have race as a factor. For example, for the average household income for Black individuals is just over $40,000. But then for white individuals per year, the average household income is around $70,000. So you can see that there are differences in income, which may actually increase your potential healthcare needs or inability to access care. And so when we're talking about income inequality and we're talking about jobs and employment, all those things play into healthcare and what you're able to access as well. And so as we kind of go into that, one really big factor that's on top of income inequality and on top of employment is also zip codes in health. And so there's a pretty big correlation factor. A recent Harvard study went out and said that actually your zip code can play more into your health than race or genetics, actually. And so maybe you've heard that, but when I first heard it, I was really surprised because you don't really think about your location in terms of how that impacts your health. But in fact, what you have access to, what you're closest to, your proximity to certain resources is going to change how you're able to access them. And so this historically has also been systemically targeted Black and brown people, especially through the practice of redlining. Redlining was a practice that started in the 1930s, for example, and actually demarcated Black communities with a red line. And so this was kind of a way of showing which properties were valuable investments. But ultimately, it started this thing of racial segregation in these areas. And so now all over our nation, we have areas and pockets that are extremely racially segregated. And I'm going to try and share a picture of that as well to see if that can help with showing how that has impacted some communities in our local area as well. Let's see if I can share that. And so, for example, this is the Delmar Divide in Milwaukee. You can see that Delmar Boulevard, a couple documentaries have kind of showcase this because of how stark the contrast is. Delmar Boulevard is considered this divide between two neighborhoods that are right next to each other. Above the line, above this boulevard, you can see that the home value is significantly less than that of the South. You can see that only 5% of the people that live in this northern neighborhood have a bachelor's degree compared to 67% below. And you can see that there's also a racial difference here. You have 99% of this neighborhood as African American, and then down here, 70% of the neighborhood is white. And so one of the quotes that I thought was really striking from this study was that the comment was saying that residents to the north are less likely to have a bachelor's degree and more likely to have heart disease or cancer. And so even in this neighborhood, you can see that there were two very different pictures of health. And that was really striking to me when I saw this study and I heard about this study for the first time. And so talking about how some of those things do correlate with education, how that does correlate with income is extremely important as well. And then just bringing it a little bit more locally, we can see that there's racial segregation in our own neighborhoods. This is Mecklenburg County. You can see on the left, on both graphs actually, both maps, they have shown the most densely populated areas with blue. So on the left, you have Black or African American populations, and then you have on the right, white or Caucasian populations. And so the most densely populated, you can see that Black Americans can be found in the center of Mecklenburg County, while white Americans can be found in the north or in the south most predominantly. And so then when you compare that to certain health outcomes on this next slide, you can see these positive health outcomes, such as having prenatal care or living longer, your longer age of death, those are also shown in blue, are found on the outskirts of Mecklenburg County, where there are predominantly white individuals as well. And so that is something that's been outlined in our own community and talks about why are there certain health benefits with living predominantly white communities. And so I'm going to go back to stop sharing, but basically talking about what is causing that is really important as well. One of the biggest issues with that has been talking about, for example, people who have more generational wealth, have more income to spend, are able to invest in the communities even more so. And so because of that, you're having neighborhoods that are very, very, that have a lot of influence, a lot of maybe influence in their local government, a lot of monetary influence. And so that's really important as well. And so this also has effects that go back to all those other social factors, such as having good grocery stores in your neighborhood. Are you able to access nutritious foods? Are you in a neighborhood that's safe, for example? Do you have sidewalks that you can walk on? Do you have clean air? Or are you next to a factory with no sidewalks or a dangerous park? And so talking about some of those issues is really important. And even today, all those effects of redlining that actually was demarcating those unsafe or risky investments have actually led to real effects today, such as the Delmar Divide in Milwaukee, or in Baltimore, for example, 2 zip codes have a difference in life expectancy of more than 20 years. So it becomes kind of interesting to talk about all of those different issues that come up in terms of location, in terms of income, in terms of access. And so I know that that's kind of a really big picture thing, but it talks about how all these different structural factors that may have impacted Black individuals in very specific ways are actually very impactful in other ways as well. And then finally, I was going to touch really briefly on medical mistrust. Within the Black community and within my own experiences, talking to some of my family members and talking to people when I go into clinics and I'm shadowing. I am pre-med, so I do have experience in the medical field and just talking to people and other patients. I sometimes get the sense that either someone doesn't feel as comfortable with their doctor or going to the doctor because of either their previous experiences or other family members' experiences, especially with Black individuals. A lot of that stems from different providers and how they might have been treated previously based on discriminatory practices. So some of you might have heard of the Tuskegee syphilis experiment. That was an experiment that actually had around 600 Black men in it, all being, some of which had syphilis, some of which did not. Some of them were control subjects. They were told that they were being treated for bad blood, but they weren't told exactly what they were being, what condition they had. And syphilis, as you may know, is a disease that can really result in terminal illness. And some of these men eventually died because of these researchers experimenting on these men, but not telling them that there was an active cure, penicillin, that could very readily cure them of this disease. And so ultimately, at least 28 men died from this experiment. And so there's been people that I've talked to that have said, I don't like going to my doctor, or I don't like going to the physician because I don't believe they have my best interest in mind. And some of them will cite maybe a family member that has experienced something very negative at the hands of a medical provider or just in general science. And so there's so many, I guess, cases like that in the past that have kind of made it so that some Black individuals, for example, do not feel as comfortable talking about their symptoms with somebody or going to providers when they do have a problem. And so all of these kind of go together and kind of outline some of the issues in terms of the structural effects, and then also kind of the way that Black people and other minority populations might perceive their medical institutions. And so I know that was kind of fast. I do want to, if there's any questions, do let me know. But I do think that I want to give like a very brief overview of a couple of the different ways that structural violences have been inflicted upon Black populations and other minority populations as well.
I'll start out with one that I thought was very striking. It was right there towards the end, Chiamaka, and thank you so much for that great overview and detailed presentation. The thing that gets me is the fear of inquiring for health care and to preventative care and everything like that. And one of the articles that we were reading for tonight was talking about that. And really, it's not only the fear of the patient to be, but also the doctors with the implicit bias, as we see demonstrated so often in systems of institutions and whatnot. Can you talk a little bit about that, and perhaps where you have seen that, and Jessica, where you may have seen that, is where you have seen that in your practice in medicine?
Do you want to take that, Chiamaka, or do you want me to?
Go first, and then I'll add whatever I can.
So just clarify for me about where we've seen implicit. Just clarify for me what you're asking.
Yeah, so where have you seen or experienced personally or other professionals demonstrating implicit bias that becomes explicit and how they interact with Black and brown patients?
Oh, I think it's pervasive. And, nobody talks about it, but I just think in years of working, I think that and in medical training, I just think I feel like I saw people treat Black and brown people not as seriously as they would treat other people. And it's hard to describe one situation, but just some of the comments that people made, something that I'll touch on later, which I think is is related to this, is that you'll hear a lot of doctors talk about patients in general as not taking responsibility. Like this problem or that problem would be solved if they would just take personal responsibility for this action or that action, with I think no real appreciation for the kind of lives that they're living and the kind of, as Chiamaka was talking about, the kind of neighborhoods they live in and what their opportunities are or what their opportunities aren't. And actually I believe in personal responsibility, but I think that people totally misunderstand it and misuse it, and they use it as an excuse for not dealing with not looking into what the real problem is and why people can't be. We have this term in medicine that I think is going out of fashion, and I don't like it. It's compliant patient, people not being compliant patients without really looking into what people's ability to cooperate, like maybe they don't take, are they able to afford their medicines, or is that why they're not complying with them?
Thank you.
Yeah, I could just add to that from personal experiences, just seeing patients, for example, I like what you touched on, Jessica, in terms of calling patients not compliant. A lot of the times I've seen it where, for example, there was a man one time that came in and we were asking why he wasn't making it to his case management because he had regular checkups for one of his conditions. And he just said that he didn't have money for the transportation. So he didn't have someone to drop him off or couldn't afford the bus fare, he couldn't even make it to his appointment. And so I guess it's easy to call it non-compliance when you're just seeing it from one side. But when you start talking to patients and kind of breaking down all the barriers to care there are, it could be transportation, it could be income, it could be neighborhood, it could be such a variety of factors that could be kind of building on that. So, I mean, it comes down to both implicit and explicit bias. But I guess one of the biases that's most prevalent is just being able to see things from only one perspective. You're only able to see it from what is coming into your doctor's office, but not seeing what happens when he goes home. So I think that's something that medicine that I hope starts moving towards, is trying to like take a more holistic view of care, not just when someone comes into a medical office, but also when they go back home as well.
Okay, I hope we answered your question, and I'll just go on and talk a little bit more about this. So to give you a little bit more background about me, I'm a family doctor. I practiced for 34 years with the underserved, and I've been retired for 5 years. And my practice just made me see everyday people who didn't get the health care they needed. And so that's why what I do in retirement is advocate for Medicare for all so that people would have access. What I'm going to speak about is the actual effect of racism and stress on some of the kinds of things that Chiamaka talked about. And a couple of things that I want to tell you are, I practiced all these years in Northwest Charlotte. My practice was largely African American. And it's only now that I'm really grappling with what racism and stress is. Now, I always knew that my patients were more at risk than other patients. I knew that they were sick earlier, that they had more high blood pressure and more cardiovascular disease and more HIV and more all kinds of things. But I don't think I ever gave a lot of thought about exactly why. I thought it was something about being Black, and most of them were poor, and something about being poor. But what I've come to understand through looking at this is, and I think that this is a bias that people have as well, but there's nothing wrong with Black bodies. It's not genetics, it's not that there's something defective about Black bodies that puts them more at risk. It's a combination of things that have to do with racism and stress and those social determinants of health that we were talking about that makes Black people more vulnerable. So I want to talk a little bit about that. So I want you to consider a couple of statistics, some of which Chiamaka has touched on, but African Americans have lower life expectancies, even when education and income are taken into consideration. So there was one study that looked at people who graduated from Yale 40 years after graduation. And the death rate in the Black people was 3 times what it was in the white graduates. Okay, so that's a group of people that we can say are pretty well educated, right? And that you wouldn't think that their social situation was the factor. Whites who have a high school diploma live longer than Black people with college degrees. And looking at something else that probably many of you have read about, in the COVID crisis, Blacks are more affected than whites. In fact, the New York Times reported today that they have 3 times the rate of infections and twice the rate of deaths. Okay, now why is this? These are different populations that we're talking about. But if you talk about the more educated group of people, what you find is that the Blacks are likely to have lower incomes and also live in neighborhoods that are more at risk than the neighborhoods that whites live in, even with comparable educations. If we look at the COVID crisis, why are Blacks more at risk? There's several social reasons that they are. They're more likely to have frontline jobs, many of which, as we've been reading about, they weren't adequately protected with masks and gowns and personal protective equipment. They're more likely to be poor or low income, which leads to the fact that they have less access to healthcare, were less likely to go to the doctor when they were sick. Even if they were diagnosed, they're more likely to be living in homes where it was impossible to quarantine or isolate themselves, because there might be several generations living and they might not have, for instance, a separate bathroom to do that. More likely to use public transportation, which has been shown to be a risk, and have poor education, which may give them what's called health illiteracy, and they might not have understood what was going on or all the instructions that they were given. Okay, now those are socioeconomic factors, and we might just stop there and say, oh, well, these are the circumstances. But if you look at those circumstances, what underlies that? And what underlies it is the things that I think that you've been studying here and that Chiamaka touched on also, which is the systemic racism that led to all those things. The systemic racism that led to fewer job opportunities, which leads to lower incomes, that the things about redlining and being prevented from living in certain neighborhoods, which puts them in neighborhoods that are more at risk. So racism underlies some of the socioeconomic factors that led to this. But racism itself has an effect. And when I talk about racism, I'm sure that you all have talked about this here, that racism isn't just what people want to think racism is, which it's not name calling. And if you don't do that, there isn't anything racist going on. There are 3 kinds of racism. One is institutional. And in the healthcare world, institutional racism creates barriers to accessing healthcare services. One is personally mediated, and that has to do with the question that you were asking, like about biases that providers might have that might lead them to give someone substandard care. And a third kind of racism is internalized racism, which means that an oppressed group actually internalizes the things that people are saying about them, that there's something wrong with them. And I will tell you that I saw that in practice. I saw African Americans who had less self-esteem and didn't think, that they were worthy of care. And also sometimes it expressed itself in the fact that although on the whole, especially now, African Americans prefer to see doctors like them, I would sometimes have them come to me and say, I don't want to see a Black doctor, which was, I think that kind of internalized racism. Several studies have shown that racism itself has an effect on health. Just last year, there was a study that looked at Black and white of similar socioeconomic status. So that means that poverty wasn't a factor. And what they showed is that African Americans had higher rates of chronic inflammation in cells. And that we know is associated with certain kinds of diseases like heart disease and neurological disease. Other studies in the past have shown that this kind of chronic stress can increase cortisol, which is a stress hormone. And studies going back a couple of decades show that Blacks have something called, they have more wear and tear on their body, which is called weathering, which means that at a given age, their bodies are actually older. In fact, sometimes as much as 10 years older physiologically as a white person of the same age. So those are things that show the actual effect of racism itself. Racism, not genetics, on health in Black people. And similarly with COVID, there's a higher death rate, and some of the exposure and so on is due to socioeconomic factors. But one of the things that you hear about COVID all the time, that the people are more at risk are people who are older or people who have underlying health conditions. Well, again, African Americans are more likely to have those underlying health conditions because of these other things that have happened. So I want to mention a couple of special areas, and I'll just mention them briefly, and then if there are questions, but some special areas around this. One is maternal health. We have very bad health statistics in this country about things like infant mortality and maternal mortality, which is mortality around the time of childbirth. And they're bad overall, but for Blacks, infant mortality is like twice maternal mortality, which should never happen. Mothers should never die. Virtually, a pregnancy and childbirth is like 3 times, it's really shocking. It's like 3 times higher. And just one story that you all may have heard is about, I don't know how many of you know about what happened to Serena Williams when she had her baby. So I see some people nodding. So Serena Williams had a baby a couple of years ago, you might know that. And she had a serious pulmonary embolus, a clot in her lung. And she was delivered by cesarean section, which is a higher risk for another pulmonary embolus. And right after she delivered, she felt short of breath. And she went to a nurse or someone, and she said, "I'm short of breath. I think I'm having a pulmonary embolus." And she told her what she thought she needed. And she wasn't taken seriously. And there was a delay in her getting appropriate care. And eventually she got one study that probably wasn't the right test, probably took a few hours. And it was only later that she got the test that she needed. Indeed, she was right. She had a clot in her lung and she was treated appropriately. But if you have any doubt that racism plays a role in delivery of healthcare, if people don't take Serena Williams seriously, and her problem isn't education, and it certainly isn't income, think about how other Black women get treated when they're in situations like that. Another big area is mental health, and I just want to make a couple of, Black people on the whole are less likely to be treated for mental health problems, although they have a higher rate of anxiety and other mental health problems. And I want to make a couple of observations about that. One is that if any of us had a child or a grandchild who, for instance, witnessed a school shooting or experienced a shooting somewhere, I think we probably would be all over that kid, making sure that they got mental health care, watching out that they didn't get PTSD afterwards. And Black children, I think, are just less likely to get that kind of attention. And one of the situations that comes to my mind from my practice was many years ago, I saw a mother brought in her daughter who was about 9. And she mentioned to me, I said, how are you doing, whatever. And she said, oh, it's rough. Her father was shot and killed last week. And she took it really hard. So we talked about that a little bit, that she had been close to her father, that it was hard on her, that, you know, as one would think. Well, they came back the following week. I can't remember why. And I said, you know, I inquired and I said, well, how's she's doing? And they said, oh, she's okay now. And it's very much my experience with my patients that it was very much, you just kind of absorb something and you go on to the next thing because the next bad thing is going to happen to you. And that there wasn't a lot of attention given to that kind of trauma or the fact that someone might get post-traumatic stress from something like that. And I think that is some of the kind of stress that we see taking tolls on Black bodies. A third area that's kind of a special area is substance abuse and the way that we've treated it. When crack was the thing that was in the news, we cracked down on crack and we gave sentences that were far higher for crack use than for powdered cocaine, which is what was in the white community. And of course now we have an opioid epidemic, which is in the white community, and now that's getting attention as a public health issue. But years ago, the crack epidemic was a law enforcement issue with very heavy sentences, and that is part of what's created our mass incarceration situation, which also, by the way, incarceration is not good for one's health either. So I want to suggest some things that might help. And one thing would be to increase the number of minority providers, which I think would help establish trust and give people a sense that they're seeing people who can understand their situation. And then there's another, which is for us to start as medical people in healthcare and as a society to name racism and address it explicitly. And very interesting to me, there was an editorial in the New England Journal of Medicine, which some of you may be familiar with. It's a very prestigious medical journal. And they called on us to do exactly that: acknowledge injustice, listen to the pain of colleagues, because there are many people, we have many Black Americans who are our colleagues, and I think many of us white people have not listened and realized that they have stories of being discriminated against. And also teach cultural competence, excuse me. And the other thing that they called for is acknowledging healthcare as a human right. Now, that may all sound obvious to all you woke people here, but I haven't seen that all of that in the New England Journal of Medicine before, and I'm hoping that means it's a real change. And then just one other thing, that I'm here talking to you, so I am obligated to bring up Medicare for All, which what we mean by that is really improved Medicare for All, which would be comprehensive healthcare for everyone, covering everyone with no copays or deductibles, so it would be ultimately affordable. And Chiamaka and John Clarkson and I are all part of the Leadership of Healthcare Justice North Carolina, which advocates for that. Now, I have to, I'm sorry to say, Medicare for All wouldn't solve every single problem that we have about what access to healthcare is and our terrible health statistics in this country, but it would help a lot. And it would help with racism because nobody could deny or restrict care anymore. And it would also help a lot to access to care. And we know that giving that kind of access to care would help with healthcare outcomes. It also, by the way, would improve economic security, which would help us make some progress in decreasing the wealth gap, which is another huge problem, as I'm sure you all probably know. So those are some of my thoughts, and I would welcome any questions or discussion about this.
Hey, Jessica, can you hear me?
Yes.
Yes, Jessica. So I posted my question in the comments here. I want to see if you have an answer for it. Is there known percentages and ratios among racial lines of those who wear masks in public and those who don't? Again, with the rationale of me asking that question is we mentioned earlier how Blacks and other minorities have sometimes a distrust of medical professionals, and if they see something out there that promotes it, it may be like, oh, I have to go against the flow. Is there anything known on those percentages or ratios that might contribute to higher cases among?
So I haven't seen anything about that. And I have to tell you, those numbers that I got from the New York Times this morning, they had to file under a Freedom of Information Act to find out what some of the racial breakdown was just of who has COVID. So I haven't seen anything, but I'll say a couple things. When I have seen, and I don't know, Chiamaka may have something to say about this. One is that I've seen it discussed that Black people are afraid to, Black men in particular, have some fear of wearing masks, that they'll be, because white people are afraid of Black men in masks. So I saw something about that, but I never saw anything that said that was actually happening, that they weren't making masks. But the other observation I will make is, so I will confess to I went to one demonstration, to one of the protest marches. And which I can say now because it's been a month, so I'm in an age group at risk, so I didn't tell my kids. But anyway, the point I wanted to make is everybody was wearing masks there. I mean, I was thrilled to see that, and they were all, everyone was wearing masks, even though it was all, mainly young people too. So I don't know, Chiamaka, if you have anything you want to add to that.
I was going to say that I don't think that there's a study out there either about that yet. It would definitely be interesting to look into, especially for the reason that you brought up with medical mistrust. And also because of what Jessica just mentioned, I had seen, for example, some Black men being fearful of wearing a mask because, as you might have seen with the recent Elijah McClain outcry, he was wearing a mask and then was treated as suspicious and eventually was murdered at the hands of the police as well. So I mean, it's definitely, I'm sure it's a concern to some people, but I haven't really seen a study about that either. So that's an interesting question.
Jessica, do you have any figures or know of any studies about the effect of the poor cannot afford organic foods. They cannot afford the better diets. They're not used to a better diet. And do you know of any studies that figure in as to what part that plays in their health being not as good?
People are very aware that that nutrition plays a part. Nutrition plays a part, right? Poor people often eat unhealthy foods because in general, one is they're often cheaper, but the other is that they often don't have access to healthy foods. The neighborhoods, they live in food deserts, they can't get fresh foods and so on. But it's not, it's all a part of it. That's a part of it. There are other lifestyle factors that are part. Physical activity is another big part of problems with health as well, and that also has to do with availability. And people who are working several jobs. And let me tell you, if this group doesn't look like a group that thinks that the poor are lazy, but I mean, they are not. And I had so many patients who'd be working 2 jobs and having kids and running around from one to the other, and all those factors about how and taking the bus to their work or whatever, so it doesn't leave them a lot of time in the day. There are a lot of factors that play into those things.
Yeah, John Clarkson, thank you so much for sending me a great article from the New York Times. I just posted it in the chat. Talks a lot about what you just said, Jessica, of the working class and the poor class, especially as it pertains right now to COVID. And the just out of proportion rate that Black and Brown Latinx populations are getting COVID and dealing with that and not dealing with it and dying a lot more than the white race, because there's so much that are required to go to work. And so we think about the discrepancies there of they have to work. I mean, like, you know, we have to work. We have jobs to do. We have our employment, families to take care of and all that. But there's this other pressure and that they're experiencing. So it goes back to Chiamaka was sharing earlier, friends, is just the whole system that is built up and around and, you know, boxing people out, if you will, segregating people out, redlining people out, however you want to think about the phrase or whatever feels good for you. It's really important for us to understand the systems and the structures that are in place right now. As I said earlier, that we have to work on the deconstruct, that we have to be very intentional about. I listened to NPR the other day, and there was a story on about how they are deconstructing some of the freeways through particular cities. There's some in Seattle that are coming down, and Portland that are coming down. And the contributor of the time was sharing, like, yeah, but it's very important for folks to speak up so they don't become gentrified spaces. And that just struck so much in me, very much like this Good Samaritan, because it takes that continued investment into the population that needs to be brought up to the equitable places of life, especially in these medical places. I think about our dear friends over at Brook Hill, just the lack of access. And that's what a lot of this comes down to, is just having the access. And that's super important for us to be aware of, and finding out where we can get engaged and where we can be present within our own local communities. It is really, really key. So got a couple more minutes. Any other closing remarks, Chiamaka or Jessica, or maybe perhaps one last question after they do a closing remark or before then?
Hey, everyone. Thanks for the shares. I just wanted to, say I really appreciate the work on like the Medicare for All, because having worked with folks and doing financial literacy, I mean, every time I look at a credit report with somebody low income, they've got medical debt, and it's just one more thing that just weighs people down. And I don't think in general that folks really understand that, and I see that as something that if we could work on that, it's a big kind of chunk we could take out of this cycle. We know it's all related, from healthcare to school to housing, it's all interconnected. But if we can take some big chunks out of some of these areas and slow that cycle, that's huge. So thank you for your work on that.
Thank you.
Nathan, this is Ron. Could I squeeze in a quick one?
Sure.
Jessica, the point you made, which to me is so insightful and kind of provocative, about the third of kind of three things, which was that Black folks have tended to kind of internalize, the feeling of being discriminated against, unliked, whatever, and that takes a toll. I don't think that, I don't know how to measure it. I suppose we can't. I don't know that it gets talked about enough, but if there's anything that we can make people feel, maybe it's what that feeling is like for people who, maybe grew up unliked, whether in their family or school, social condition, or whatever. So I just wanted to compliment you or thank you for bringing that up.
Thank you. Yeah, it's real.
Absolutely. Well, Jessica and Chiamaka, thank you so much for your time and being with us and sharing these important facts. Friends, please continue to learn on these topics and continue to expand. We send out the pre-readings. If you didn't get a chance to do that, the reading, the watching, the listening, please do so. Please check out that New York Times article shared to me by John Clarkson. And if you guys haven't read that already, it's such a good thing. continue to learn, continue to grow in this arena. Next week, our Christian friend will be back with us. He and I will share in conversation, or I'm going to continue conversation, systemic racism, and how does the faith community need to participate in the dismantling of some of the structures that are in place that are oppressing and holding people back. So as always, I hope to see you there. I hope you, if that's something that strikes your heart chord and you know somebody else that wants to be a part of that, invite them, because that would be great. And then that will be the last of this iteration of these conversations. We'll take a couple weeks break, but then we're going to kick it back off in August. So please look forward to that for this Monday night group. We're going to continue doing it. And one thing that I really want to celebrate on Wednesday at 11 a.m. Live, and then to be shared again at 8 p.m. on Wednesday, James is going to have a conversation with Angela Pleasance, who is the new pastor at South Tryon Community United Methodist Church. And I know you don't want to miss that one, because you get to meet Angela through conversation and hear her wisdom and shared wisdom and conversation with James, which is, you know, our sibling church. And so we want to continue to grow together and thrive together in our mission and ministry. So thank you guys so much for being here. Bailey Cottle is going to close us in prayer this evening.
Thanks.
Thanks for being here. If you'll pray with me. Loving and healing God, we thank you for placing it on our hearts to be here tonight. Whether that here is in our own house or in our office or wherever in the world that we are, we thank you for calling us into conversation. We thank you for the presence of our speakers who are willing to spend their evening bringing us this education and discussing it with us. As we move forward from this, we ask that you strengthen us and embolden us to do something with this information, to put it to work in our various communities. We ask for the courage to call out racism, to have those difficult conversations with people when they have said something or done something. It's never easy, and we don't always feel prepared for that, but give us the strength and the courage and renew us, as it can be tiring to have those conversations. But also give us the strength to never truly tire from this work that is so deeply important. As we join with our brothers and sisters all over the world and in the U.S., we ask that you always give us the strength to continue fighting for the justice that is so holy and sacred to your mission for us on this earth. And we ask that you give us this strong community, that we continue to educate ourselves and educate our neighbors in the best that we can, and that we also learn from our neighbors who have had different experiences from us that can teach us so much more than a statistic. And so we thank you for this time, and we thank you for opening our hearts to these conversations and these experiences. And we ask that you strengthen us and hold us together in this community in order to bring us closer to your will, that is a shared world of peace and love and service to one another, and not one of racism and injustice. In your loving name we pray. Amen.
Amen. Thank you all for being here. Have a great night.
Thank you.
Thank you.
Thank you.
Thank you.